Hello everyone, this is Dr. Gary Siskin, and I'm going to be continuing my lecture series on the uterine fibroid embolization procedure. Today I'll be focusing on the technique used during this procedure. In my previous lecture, we spent a lot of time talking about patient selection. Once we see a patient in the office, we've appropriately assessed them and determined their candidacy for UFE, we can make plans to schedule their procedure. Most procedures are being done in a hospital setting, but a growing number are being done in office-based labs or in ambulatory surgical centers. Prior to any procedure being performed, we usually obtain some labs, including a CBC, BUN and creatinine, as well as coagulation studies, but I would say that you should follow the same standards that you do for other healthy patients undergoing angiography at your institution. In terms of an endometrial biopsy, we do tend to biopsy all patients with a significantly abnormal bleeding pattern or a significant change in their bleeding. We certainly like to biopsy all postmenopausal patients due to the risk of endometrial cancer or endometrial hyperplasia. We do know that performing an endometrial biopsy and MRI in appropriate patients has the potential to change management in as many as 5% of patients. And this speaks to the importance of the clinic-based consultation that we have with our patients prior to performing a UFE, because this is where we might make the suggestion that these tests be performed. We do routinely make sure that pap smears have been performed within 1 year of the consultation, and this is important because we have found patients that have not been tested for many years, and we've also found abnormal results that were never followed up. Many patients ask us whether or not they should have an IUD removed. Now, in theory, this may be associated with a higher risk of post-procedure infection, but this is not proven at this time. And that's why we don't routinely mandate removal of an IUD prior to UFE. Every UFE procedure begins with arterial access. Most centers use unilateral common femoral artery access for their procedures. A small number of centers use bilateral femoral punctures for fibroid embolization because this is associated with reduced fluoroscopy time and procedure time without an increase in complications. The only issue there is that you need 2 skilled operators in order to pull that technique off. These days, there are an increasing number of centers using radial access for UFE, and this is associated with a low rate of access site complications and comparable radiation exposure levels and fluoroscopy times compared with femoral access. At our place, we use right common femoral artery access for our UFE procedures. We place a 5 French sheath and then use a 5 French Cobra glide catheter in order to gain access to the contralateral internal iliac artery. At that point, we perform an angiogram. And I think you can see in these pictures why the 30-degree LAO view is advantageous. On the image to the left, which is an AP view, you can see the uterine artery running across the pelvis, but it's hard to see the origin of the vessel due to overlapping branches of the internal iliac artery. When you oblique the II to create a 30-degree LAO view, all of a sudden the origin of the uterine artery becomes a bit more apparent and facilitate selective catheterization. Under road mapping guidance, we then pass a microcatheter into the uterine artery. And we generally use microcatheters because we try and minimize spasm and vessel occlusion due to the space-occupying nature of some of the larger angiographic catheters. However, we've all seen patients which have very large uterine arteries, and in those patients, you can easily use 4 French or 5 French catheters for these procedures. Once the catheter is in place within the uterine artery, we typically perform an angiogram to help refine the catheter position prior to embolization. We are looking for the cervical vaginal branch of the uterine artery because it's desirable to place the catheter distal to that branch. The reason why we do that is we want to avoid non-target embolization into that branch because preserving patency of this vessel may reduce the incidence of sexual dysfunction after fibroid embolization. This is another example of a cervical vaginal branch. On the image to the left, you can see the catheter tubing near the lower right-hand portion of the image. This is a uterine arteriogram, and just a few centimeters beyond the tip of the catheter, you can see the cervical vaginal branch arising inferiorly from the transverse portion of the uterine artery. As a result, if you look at the image on the right-hand portion of the slide, you can see that we repositioned the catheter to be distal to the cervical vaginal branch. The next step of the procedure is to determine what embolic agent we're going to use. You have to remember that the goal of the UFE procedure is to maximize the likelihood that the patient will experience symptomatic improvement, uterine and fibroid volume reduction, and fibroid infarction after embolization. So the question here is, what embolic agent will help us achieve these goals? It's fair to say that the thinking on this has definitely evolved through the years. When we first started doing fibroid embolization, I think most of us thought that anything we use will work. Then we started doing the research to either support or refute that statement. First, the research involved single agent studies. These were studies that simply looked at one embolic agent and then studied the outcomes when these agents were used for UFE. And each of these studies supported the use of their respective embolic agent for UFE. Then we got smarter. We started performing comparative studies, and we've learned through the years that it's essential to understand the differences between the available embolic agents through comparative studies. Single agent studies are just not enough because in a vacuum, they usually show positive outcomes. We need to see comparative studies because we want to optimize our technique and we want to determine which agents ensure the best outcomes for our patients. For your reference, these are several of the comparative studies that have been performed through the years. I'm not going to spend time talking about all these studies, but the one thing we definitely learned is that some agents work better than others. And in general, these studies show that particulate PVA and embosphere microspheres are safe and effective for fibroid embolization. Given the fact that this is what all those studies showed, it made logical sense to compare these embolic agents to determine if there were any advantages in terms of fibroid infarction or clinical response. So in 2004, Jim Spies looked at this and did a randomized study comparing a limited microsphere embolization versus an embolization with PVA particles to near stasis. And that group looked at post-procedure symptoms, symptom severity and quality of life improvement, the degree of fibroid infarction, and patient satisfaction. And simply put, they found equivalent outcomes with both agents. This study led to the generally accepted idea that these two agents are the standard agents to use for fibroid embolization, and this was later validated in subsequent studies. In fact, agents that have been introduced after this study have usually been studied in comparison to one of those two agents, and it's usually been embosphere microspheres, and those studies have to be done before a new agent is considered acceptable for use during this procedure. Now, I don't want to forget about gel foam, because there is a significant body of experience from Asia which have demonstrated the success of gel foam for fibroid embolization. There's been at least 3 comparative trials which have shown that gel foam is associated with fibroid infarction rates that are comparable to particulate PVA and embosphere microspheres. The thing to remember is that there are several different ways to prepare gel foam, so standardization of technique and comparability of data across these studies may in fact be difficult. With that initial research out of the way, new agents started to be developed. One of those was contour SE microspheres, which were microspheres consisting of PVA. When we looked at comparative studies involving this agent, we quickly realized that this agent does not result in the same degree of clinical improvement and fibroid infarction as both particulate PVA and embosphere microspheres. The legacy of this particular embolic agent is that comparative studies are extremely important before deciding to use any new embolic agent for fibroid embolization. So in other words, we learned that not everything works. When bead block microspheres were released, the available single agent and comparative studies evaluating this agent had mixed results, with high rates of treatment failure when using 500 to 700 micron microspheres. Embolization microspheres are another relatively new agent that was released, and to date, only single agent studies have been performed. These studies have shown that embolization is safe and effective for this indication, but no comparative studies have been completed to date. In other words, we actually need to prove what works. So based on all of this data, particulate PVA, embosphere microspheres, and gel foam have the best reported outcomes for fibroid embolization. Contour SE microsphere should not be used for fibroid embolization. Comparative studies have shown that B-block is non-inferior to embosphere microspheres, but the data has been mixed on the outcomes after fibroid embolization. And finally, when it comes to embolization microspheres, comparative studies have not been performed, which really should limit its use for fibroid embolization at this time. So once we've selected our embolic agent, we're going to begin embolizing our target vessels. And once we start to do that, it's fair to say that we have to know when we're going to stop. This is going to vary based on the embolic agent used and the portion of the uterine arterial vasculature being targeted for embolization. When it comes to using particulate PVA, we know that PVA particles proximally aggregate. This tends to lead to an occlusion that may be more proximal there than intended, and ultimately that leads to stasis of flow. And this is why stasis is typically the endpoint that is used when this agent is what we select for fibroid embolization. And you can see in many of the early studies, PVA was used and stasis was the endpoint. And we know with reasonable certainty that using this endpoint with this agent leads to symptomatic improvement and fibroid infarction after embolization. Now, what about embospheres? Well, the initial experience with this agent made it immediately apparent that it resulted in a less extensive occlusion than what was seen with PVA. And this was thought to occur because these microspheres don't clump or aggregate like PVA. The endpoint was described as a pruned tree appearance with occlusion of the feeding vessels to the fibroid with the main uterine artery open with slow flow or near stasis. And this was initially not very easy to define or replicate from operator to operator. In time, this became better defined as a limited embolization endpoint, and it was defined as slow injection with free flow in the uterine artery, stasis or near stasis within the vessels of the perifibroid plexus and the distal uterine artery with no residual hypervascularity to the fibroids, and flow reduction in the proximal uterine artery. The secondary signs of this endpoint included easy reflux into the ovarian arteries when it had not been present earlier, and filling of cross-uterine branches without filling of intervening fibroid tissue. I always think the description made by Rich Slansky-Goldberg at the University of Pennsylvania made this limited embolization more objective. He defined slow flow as persistent contrast in the main uterine artery for at least 5 to 10 heartbeats. And this is what we use for our endpoint at our institution. Once that endpoint is reached, the catheter is typically left in place for a few minutes with a repeat angiogram performed at that time. This allows us to look for a redistribution effect, which acknowledges that stasis may in fact be a transient finding and flow may return to an embolized vessel. If that is seen, in other words, if we see additional flow in a vessel that we thought was embolized, we will simply inject additional embolic material until that initial endpoint is once again reached. This strategy changed the thinking regarding the embolic endpoint and made it more desirable to achieve a more limited embolization than what was previously sought with particulate PVA. And it was felt that this led to less overembolization, which reduced the risk of complete occlusion of the uterine artery, which was thought to have led to excessive pain and myometrial injury. The good news is that it led to expected rates of symptomatic improvement and expected rates of uterine and fibroid volume reduction. In time, we also learned that this approach optimized fibroid infection rates. So as we look closely at embolic endpoint, we learned interesting lessons. First, we learned that all embolic agents are not the same. We learned that as new embolic agents are developed and assessed, we can't assume that they're going to behave similarly to our existing agents. So each new agent has to be assessed appropriately to determine the safety and efficacy and understand the modifications in technique, such as which size are you going to use and which endpoint are you going to use. We have to understand those modifications in technique that need to be made in order to optimize results with that particular agent. We also have to remember to be careful of false endpoints. It's always important to recognize when a false endpoint has been reached because that can cause under-embolization. This might be due to spasm, which can be secondary to guide wire and catheter manipulation, or it could also be due to clumping of the embolic agent used due to either poor suspension or rapid injection. It's important for us while we're doing the procedure to recognize this and address it in order to avoid potential treatment failure. Once we've successfully embolized the contralateral uterine artery, we use a Waltman's loop technique to move the parent cobra catheter from the contralateral internal iliac artery into the ipsilateral internal iliac artery. At that point, we once again do an angiogram in order to locate the uterine artery, and under road mapping technique, we'll advance a microcatheter into the ipsilateral uterine artery. And here are two pictures showing the catheter being positioned within the right uterine artery, Once we've embolized both uterine arteries, we like to perform a completion aortogram. And we do that to make sure that the uterine arteries have been appropriately embolized and that there is no longer any fibroid perfusion. Here's an example of a typical aortogram after bilateral uterine artery embolization. On the picture on the left, you can see the dilated uterine arteries. And by the way, you can also see a prominent right ovarian artery. And upon uterine artery embolization, showing the picture on the right, you can see that both uterine arteries have been occluded, and you actually can't see the distal aspect of the right ovarian artery, which we're going to talk about in just a second. The completion aortogram also enables us to know if there are any other blood vessels supplying the fibroid that may need to be embolized. And most notably, this includes the ovarian arteries. And the ovarian arteries at least have the potential to provide flow to the uterus through uterine ovarian anastomoses. Back in 2002, Mahmoud Razavi took the time to classify these anastomoses. In a type 1 anastomosis, the uterus receives some perfusion via the ovarian artery via an anastomosis with the intramural uterine artery. In these cases, uterine artery embolization will typically address this additional supply, so ovarian artery catheterization and embolization is not usually needed. In other words, the ovarian artery joins the uterine artery before the uterine artery supplies the fibroids. In a type 2 anastomosis, the uterus receives direct supply from the ovarian artery, and there is no communication between the uterine and ovarian contribution to the fibroids. When this is seen, ovarian artery embolization is needed to ensure complete fibroid infarction. What we know is that patients with type 1 or type 2 anastomoses can have their ovarian arteries safely embolized with no increases in the rate of permanent amenorrhea. In rare cases, the ovarian artery provides the dominant supply to the uterus and fibroids, and this is usually associated with an absent or disproportionately small uterine artery. And when this is seen, ovarian artery embolization is definitely needed to ensure complete fibroid infarction. And here's just a nice case showing what I mean here. You can see the left uterine artery is markedly larger than the right uterine artery, and in fact there is a right ovarian artery which is a dominant source of supply to the fibroid. When we do ultimately choose to embolize this vessel, I show a picture here of a Michelson catheter, which is a great catheter to use to select the ovarian artery or any small artery arising directly from the aorta. There are other potential sources of collateral supply beyond the ovarian arteries. These include the inferior mesenteric artery, omental branches, lumbar vessels, and the round ligament artery. Before finishing this lecture, I would like to make just a few comments on cone beam CT and its potential role in UFE. Some authors out of Montefiore in New York City have suggested that post-embolization non-contrast cone beam CT can be helpful to reveal incomplete treatment of the uterus, and it can help identify significant collateral supply to the uterus. It helps by directly visualizing areas of the uterus that did not retain contrast after UFE, and this may make it more likely that these areas of the uterus are supplied directly by an ovarian artery. They have suggested that if the cone beam CT demonstrates adequate contrast retention throughout the uterus, then aortography and selective ovarian artery catheterization may not be helpful or necessary. But if it identifies an incompletely treated uterus, then additional aortography and additional selective catheterization may in fact be more likely indicated. When the procedure is completed, we use closure devices or manual compression for patients with femoral access. We do frequently hear from patients at their post-procedure visit that they have some discomfort when closure devices are used. It just might be for a longer period of time than you might expect. For patients who have radial access, external compression devices or manual compression may be used for hemostasis. In conclusion, the UFE procedure makes use of standard angiographic and embolization techniques that are well within the skill sets of most interventional radiologists. Careful embolic agent selection based on clinical trials and techniques based on the characteristics of the selected agents are the two factors which are most likely to impact the clinical and imaging success associated with UFE. When the patients do come to the hospital, they get IV access and they also have a Foley catheter placed. And the reason why we do that is to immediately remove contrast from the bladder during the procedure and to help make our patients more comfortable while they recover after the procedure.